Oh, for Pete's sake. Let's see if I can. All right. I think we're rocking and rolling. Okay, so I apologize. Okay, so here we go. We are working on, make sure I'm recording this, or what's the point? Okay, so exoskeleton. We're going to be covering the osteology. We're also going to be looking at the dynamic control, so the muscle control. This is a huge swath of anatomy that we're going to be breezing right through. So my estimation is that you remember the basics, and we're going to be kind of laying over top of that movement. If this is a fuzzy area for you, if you don't remember what the multifidi are, if you don't remember what the transversospinalis group does, that's on you to go back and review. We just can't review anatomy and do kinesiology. We're going to be looking at the functional interactions. We're going to look at what happens when you fix one end and move another. So that's where we're kind of going with this particular lecture. So the spine is a wonderful, wonderful thing. It keeps us upright against gravity. It gives us a base for the rest of our body to move off of. It attaches things like ligaments and our ribs and the pelvis, which connects us to our lower legs. So it is pretty much vital to everything that we, every movement that we do. The spine also functions to protect the spinal cord, which is what gives us movement, right? And because of the curvature, Dr. Hallam probably talked about this in anatomy, the curves are actually designed as shock absorption. So if you have a person who's very straight spine, if you take an x-ray and there's very little cervical lordosis and their thoracic spine is fairly flat and their lumbar spine, they have very little lumbar lordosis. When they jump off a two-story building, which I don't advise, their body is not designed to absorb shock. They, instead of absorbing shock like a spine with curves does, they just kind of jam up against each other. So there's a lot of compression that occurs, and so they suffer more risk of failure of the bone. So the spine curvatures give us that shock absorption. So if you have somebody who has a flatter lumbar spine, they don't handle things like jumping and running as well as someone who has better curvature. The vertebra is the basis for the spine. Nothing you guys don't already know, but I think the important things are to pay attention to the posterior elements and the design of the vertebrae. Every part of the human body is amazing, and the vertebrae is no less that. So the vertebral body itself is designed to absorb compression, right? It has trabeculae, it absorbs compression. The discs in the middle help that as well. But the other part, the posterior elements, are also designed to transmit that force from the muscles and the ligaments that are pulling on the spine to the vertebral body. If they didn't transfer those forces, those small elements in the posterior aspect of the spine would not be able to endure much force. So the forces that are transmitted through the spinous processes, through the articular pillars, through the facets, all share the load with the vertebral bodies and back the other way. So it's a wonderful design. So you have the lamella, which actually, I'm sorry, the lamina. I just made my own bone. the lamina that is between the transverse process and the spinous process. If you imagine the forces that are going through transverse processes and spinous processes from muscle pull, that lamina is under a lot of force. The spinous processes and transverse processes themselves provide a longer lever for muscles. The axis for the spine is pretty much in the center of the vertebral body. The farther away you get from that axis, the longer the moment arm, the better the ability to have an impact on the movement, right? The closer you are to the axis, the less effect you can have, the farther away, the better. So the length of the spinous processes and the muscle attachments on those give them a better advantage. The pedicles are those important connections between the vertebral body and the posterior elements. A lot of force transfer goes through the pedicles. And then the articular processes, you're going to talk about a lot in manual therapy. They are the capsule joints, the synovial joints between the vertebra above and the vertebra below. A lot of things can happen in a synovial joint, right? Arthritis can happen. It has a capsule, so you can have tightness of the capsule. So we talk a lot about the facet joints and the articular processes in manual therapy. So they are not to be forgotten either. Quick review of the stabilizing tissue in the spine. These ligaments you guys already learned, but I want to talk about their positioning and their primary function. So this may be a quick review. The anterior longitudinal ligament is the ligament that runs on obviously the anterior surface of the vertebral bodies. So this, can you see you guys can't see my pointer, can you? So it's, I'll plug this in. Good Lord, I'm falling apart today. All right. So running. I can't even, there it is. So along the anterior surface of the vertebral bodies. That makes it the one ligament that's actually anterior to the axis of motion. So being anterior to the axis of motion, when does that ligament get tight, on flexion or extension? Extension. It is the one ligament that we're going to talk about that gets tight on extension. All of the others are posterior to the axis of motion, so they are all going to get tight on flexion. The posterior longitudinal ligament is the purple one here. It comes right behind the vertebral bodies. Has a primary function for keeping the disc in its place. It gives support to the posterior aspect of the disc, which is the area that most likely weakens when you have a disc herniation. It has some fibers that actually integrate with the discs. So it's a big support for the disc. The ligamentum flavum, the blue one here, is in the spinal canal itself. And did Dr. Howland talk about the important feature with the ligamentum flavum? Is that something that you guys talked about? What is important about that one as opposed to the other ones? It has the most elastin in it. Yeah, it is the most elastic. It is 80% elastin, 20% collagen. Why is that important? Why does that matter? Form follows function, right? Why does it matter that that particular one returns to its prior state easily? Right, it is bumping right up against your spinal cord, right? They are like buddies. So if you bend forward and the ligamentum flavum stretches, and then when you come back up to normal extension, if the ligamentum flavum doesn't return to normal motion, it's putting pressure on the spinal cord. So it has to be able to return to its normal position easily and quickly so that it doesn't put any pressure on the spinal cord itself. The supraspinous ligament, the interspinous ligaments are the green ones, and they kind of run in between the transverse processes and the spinous processes, giving them some integrity. The supraspinous ligament, though, the yellow one here, runs all the way from ligamentum nuchae at the cranium all the way down to the sacrum. It surfs right along the top of the spinous processes. Its one primary feature is it has the farthest, it's the farthest from the axis of motion, giving it the best ability to limit flexion. So it's very, it's a strong support when you go into extreme flexion. You guys watch those video shows, those America's Funniest Videos and all that kind of stuff. You watch those. They're painful. I love them. I laugh. And then I watch somebody do something like swing on a tire swing and then come off and they land right here and their body folds in half, right? Have you seen those? And you go, oh, that had to hurt something, right? That had to break something. The supraspinous ligament is a very important ligament in preventing damage when you flex too much like that. It's a very strong ligament. You guys dissected it out, right? Could you tell how strong it was just from your dissection, or did you not pay any attention to it? Because it's only a ligament, not a bone, right? Ligaments are so important. All right, the other important feature of the zygoapophyseal joints or the facet joints, Z joints, you might call them Z joints. Typically, we're going to call them facet joints because it's easier to say. They join each vertebra together. So the top vertebra is joined to the one below it at their facets with a capsule, a synovial joint. And all of the vertebrae, as you move through the spine, there is a shifting of the direction of the facet joints. It's primarily related to the function of the joint in that portion of the spine. And we're going to look at that here in a second. But it's designed to either control a rotational force, maybe it controls flexion extension, maybe it controls side flexion not so much. So depending on the need in the joint, it's going to change its orientation. The lumbar spine moves very much into the frontal plane because that way, with the lumbar curve of the spine, it prevents one vertebrae from sliding forward on the other. They also give some space to the disc and support the disc. So they're important for that too. And it gives stability to the segment. And we're going to talk about coupling here in a little bit. So when one vertebrae moves, the one below it and the one above it has to move, right? They're all connected together. Unless you have a totally ruptured capsule or you have a facet that's completely been severed off, if one vertebrae moves, the one below it and above it have to move too. So we're going to call that coupling in the spine. And there are typical movement patterns that we see because of the coupling of the spine, because the facet joints pull and tug a certain way on the vertebra above and below. And then the disc, obviously, and all the ligament support. So we're going to talk about that again, but the facets are very important in that aspect as well. So this is the capsular joint, or what it looks like, the capsular structure of the facet joint. It basically resists all extremes. They're fairly flat surfaces that just slide on one another. So we don't have to worry about convex, concave in a facet. They just glide. The available motion depends on the facet orientation. So whether you have more rotation or more side flexion or more flexion extension depends on their orientation in what plane that they're oriented in. The thoracic region tends to have much more, much tighter, much more taut capsular joints. but you also have the integration of the rib in that circumstance. So the motion in the thoracic spine is very much limited because of the capsular tightness and because of the rib attachments. The intervertebral movement, or the disc, the movement one vertebrae on the other, has three different interactions that you need to pay attention to and that influence that coupling motion. The transverse and spinous processes are attached with ligaments, and they have muscles that run in between them. So transversospinalis muscles run between two segments, or maybe they jump a segment and go to the next one below. Those muscles live in that groove between the vertebral body, or between the transverse processes and the spinous processes. That's where the transversospinalis muscles live. They're very short, they're very small. We're going to talk about their importance here soon, but they pull and tug on those transverse and spinous processes. And then the facet joints obviously are very important for guiding and directing movement. They don't have a whole lot of range available because of the capsule. The other very important part that we're going to talk about is the interbody joint, or the disc, basically, right? The joint between the vertebrae above and below. So it's not just the disc. Like, you know, you look at our skeletons upstairs and they have two vertebrae and then they have this like plastic thing that we've shoved in there. They're not like that. They're integrated into the bones above and below. So there's a direct connection. The disc actually is connected via an end plate. So there's an intimate connection between the disc and the vertebral body. The disc itself, you guys know this, it's the shock absorber of the spine. Carries about 80% of the load above it. Again, the vertebral body is the axis of motion. And thanks to our disc, we have space for our nerves to exit between the two vertebral bodies. So it provides that space for the nerves. So if you have somebody who has a loss of the integrity of a disc, that's when they start having neural symptoms, because the space between the foramen is getting smaller and smaller and compressing them. And we actually lose height as we go through the day. So at night, you're lying horizontally, gravity has no effect on you, your discs rehydrate. So there's more space in between, and you're actually a little bit taller. But then as the day goes on, gravity does its thing. Gravity's not our friend. Gravity does its thing. The disc lose a little bit of water during the day. They compress a little bit. So you might have somebody complaining about increased neural symptoms later in the day. And that could be because that disc is actually losing a little bit of its height. The foramen is getting a little smaller and putting a little bit more pressure on the nerve roots. That's just one possible explanation for that. They also allow one vertebral body to kind of rock on the other. So it's like you're sitting on a therapy ball, right? And it lets you kind of rock in different directions. So it does allow motion, forward, back, rotational, the whole deal. The disc itself, again, this is review, the annulus fibrosus and the nucleus pulposus. You hear it talked about as a jelly donut. Well, it's really not that easy. The goo in the middle, if you were to cut a jelly donut and set it on a table, the jam would probably likely run out on the table. The disc material in the spine is not that viscous. It's a little thicker, but it still has kind of a hydraulic compression ability. So it absorbs force. That's its job. There is no blood supply, no nerve supply to the innermost parts of the disc. There are no pain fibers on the innermost parts of the disc. It's not until you get to the outer, like 1/3 layer of that annulus fibrosus, where damage to the disc is going to be reported by your pain nerve endings. So if somebody's starting to report pain in their low back that's related to the disc, the damage is in the outer 1/3 of the layer of the annulus fibrosus. Again, just like the cartilage, diffusion is what provides nutrients to those aspects of the spine. So compression and on and off compression is what's hydrating things. So if you're immobilized, if you lay around the bed too long, you're not getting that kind of nutrition into the disc. So movement is extremely important when we talk about providing nutrition to the discs. The other really cool thing about the disc is it's designed to handle shear force. It's designed to handle distraction force, and it's designed to handle torsion. And it does that because of the orientation of the annulus fibrosus fibers. So they're not all just stacked up like this all the way around. They're not just stacked up like this all the way around. They run at different angles to one another. So when there's some torsion applied, a portion of the fibers get tight. When there's distraction applied, the portion of fibers get tight. When it's compressed, the portion of the fibers from the pressure from pushing out on them get tight. So it responds to all of those forces. So this is kind of that compression force that I'm talking about. So when you get compression from above, it takes that force and distributes it out. It distributes it all the way through the disc so that the whole disc will take the compression from whatever direction you provide it. And that's that hydrostatic kind of pressure that it can handle. It does that because it's mostly water. If we lose water as we get older, as I get older, things get stiffer, the water kind of works out of our system. Things don't respond as easily because we're drier. And if we're drier, things start to break because the water isn't there to help support the structures. Let me see if I want to. Okay. There have been some studies on disc pressure and when the disc pressure is the greatest. If you look at this chart at 100, that's kind of where they said standing upright with no weight or anything. This is 100. This is where we're going to start the scale. It gets decreased pressure, obviously, when you take gravity out of the equation. So when you lie down, flexed, so that's like the fetal position there, you have more pressure in your disc than you do if you're lying flat on your back. And then as we go up fighting gravity, believe it or not, the worst position for pressure on your disc is in a seated position, flexed forward, so slouched forward, with weight in your hands. So that puts the most pressure on your disc. Having your body in that seated position rather than the standing position magnifies the pressure. So if you're working with somebody who has a problem with their disc, if they have damage to their disc and you're working on rehabbing them, it's important to know what positions to avoid. And that standing flexed forward, we talk about that a lot. Don't stand in this position because gravity has a much longer moment arm on your disc. This is just to give you some reference. And I think the most important thing in this slide, because you've seen this one before, it's just comparing the different vertebral segments. The first column is cervical, the second column is thoracic, and the third column is lumbar. And we're looking at their changes in size and structure on that first column. So your cervical vertebrae, their primary job is to get your head oriented to where you need your head oriented. The rest of our body is kind of a subject to the brain and the eyes. That's how we avoid a mastodon trampling us down when we were Neanderthal, right? That's how you could direct your eyes to know where to throw the spear to kill your food for supper, right? Our job is to get our head oriented where we want it. So that's the cervical spine. The thoracic spine, the main job there is to protect the vital organs, heart and lungs. So they're going to look a bit different because they have the rib attachments. The lumbar spine is designed to take the weight of the body above it and to hold everything upright. So you'll see a much larger vertebral body, much sturdier spinous processes. The facets are much larger, so they're just designed to take weight. So if I were to hand out a vertebral body to you right now, you should be able to go, oh yeah, that's thoracic. Oh yeah, that's lumbar, just by looking at the shape and the design of it. The orientation of the spinous processes and transverse processes, that's good to know. For my purposes, that's not all that important, but the important thing is when you look at the spine in the thoracic region, the spinous process is not in the same plane, not in the same orientation as the body of the vertebrae, right? So when we go to palpate the thoracic spine, when you palpate the spinous process, your vertebral body is actually a segment above. So that's probably the one kind of big thing to know for future reference. And then facet orientation. We talked about this too. So the facet orientation is about 45 degrees in cervical spine, about 60 degrees in the thoracic spine. And then in the lumbar spine, it's very close to 90 degrees when you have them stacked up like this. When you put yourself in a lumbar lordosis, right, that gives you that ability to hold back on the weight of the body, orients it so that the one doesn't slide on the other. Okay, so this is a lot of words. I hate to put this many words on a slide, but we talked about that coupling motion. It's mostly seen with lateral flexion and rotation, so side flexion and rotation. Flexion and extension do have an impact, though, on the movement, and we're going to look at that. So in order for a motion to occur, such as flexion or extension, there has to be some other impact, well, let's say side flexion and rotation. So if you side flexion actually is a combination of rotation, side flexion, flexion, and extension. It's a combined movement. You can't, there's no such thing as just taking two vertebrae and side flexing them. There's a component of rotation when you do that. It differs by the area of the body. Part of that is because of the design of the vertebrae. Part of that is the thoracic region is ruled by the ribs. If the articulating facets matter, the disc matters, how flexible the connective tissue is, that matters. And everybody's put together differently. So when we get to manual therapy and you hear about the Fryette's laws, and Dr. Schwartz will share that over and over, Fryette's laws, the important thing to remember is they are general guidelines. They truly are not laws. They come into some skepticism in most recent years because they find a lot of people who don't follow these specific laws. So when we go to manual therapy, you have to keep that in mind. Some people respond differently, and so you have to get used to feeling the movement rather than just following this rote law that we talk about. But there is a general group of population that does follow this. So, and that's how some of your manual therapy techniques are devised. So it's basically saying spinal coupling occurs when a movement in any given plane is associated with an obligatory movement in another plane. So Fryette's law number 1 only applies to thoracic and lumbar spine. The cervical spine kind of does its own thing in some cases because it's very differently aligned. But when the thoracic and lumbar spine is in neutral to slight extension, your vertebrae will side bend and rotate in opposite directions. So if I side flex to my right, that means there is a slight rotation left. Okay. If I side flex left, there's a slight rotation right. That's only in neutral or slight extension. If I rotate right, there's a slight side flexion left. Law number 2 says that if you're in flexion or end range extension, so if I move into flexion and I side flex, I'm going to rotate the same direction. If I'm in flexion and I rotate right, I'm going to side flex right. And law number 3 is when motion is introduced in one plane, it will modify or reduce motion in the other 2 planes. This is the law that I stand behind. The other 2, you will find a lot of inconsistencies, but this one is very consistent. If I take up motion for rotation, I'm going to have less motion allowed for side flexion. If I take up rotate, or if I take up a lot of side flexion, I'm going to have less motion available for rotation. And you can see that when I side flex right, I'm in neutral, I'm going to rotate left. If I start in rotation left and then I side flex, I have more rotation, less side flexion, right? It makes sense intuitively. You're tightening up the tissues, so you have less slack available for that second motion. And why do we care? That's your question. Who's thinking that? Why do I care? When we go to do manual therapy techniques, and some of you may have seen somebody popping a back or, doing a manipulation. When you do a manipulation in the spine, what you need to do is put all the other segments above and below the segment that you're interested in. You need to take them to end range, so that when you move the segment that you want to move, all the energy goes to that segment. You're not taking up slack up and down the spine, right? The slack is only in that segment so that you can get the manipulation that you want. So we have to know how to take the tissue up on either side so that we can focus on that one segment. That is the whole point of understanding Fryette's laws. So it will make more sense to you when you get to manual therapy courses and your spine courses later. All right. The osteokinematics of the vertebral column, obviously we have flexion, extension, lateral flexion or side flexion. You can use those interchangeably. I tend to use side flexion and rotation. And when we talk about feeling rotation in the spine, we feel movement from the spinous process. So when you rotate someone to the right, their spinous process actually goes left. So as you palpate down somebody's spine, and you gotta, this probably doesn't work. They never work in this room. Oh, it does. So you're palpating down, here's spinous process, right? You go, boom, I feel that one, I feel that one. Oh, that one's way over there. Oh. So this one is rotated right or left. The segment itself is rotated right or left. You call rotation by the anterior aspect of the vertebral body. I guess that's an important point I should share. Right? So the vertebral body, the front of that vertebral body rotates right, which makes the spinous process go left. So this is a right rotated vertebra. Okay. The craniocervical components, the upper cervical components are very different from the rest of the spine. So we kind of talk about them individually. So we're talking about the occipital atlantal joint. This is biconvex. So both surfaces are curved toward each other, convex toward each other. I can't remember what the number is, but they say when you actually turn your head to the right, you actually drop like 2 millimeters or something, because you have a convex surface on a convex surface, and when you rotate your head, they slide off one another. So you actually are shorter with your head turned than, I don't know, I've never measured it, but that's what they say. The atlantoaxial joint is C1 and C2. And these are kind of convex too. They're a little more flat than convex in my humble opinion, but and what primary motion occurs at the AA joint? The AA joint. What's the primary motion? Pretty much the only motion that occurs there. You guys know this. Come on. Rotation. Thank you. Could have been here all day. Right? About 50% of the cervical rotation occurs at the AA joint. We don't even look at flexion and side flexion and extension at that joint when we go to doing mobilizations and things like that, because the rotation is the primary component. From C2 to L5, so now we're going all the way down from cervical down to the lumbar spine, or to the lower lumbar spine. The facet joints glide with movement. I said they're basically flat. We don't have to worry about a roll. Woohoo, right? We just have to worry about them sliding on one another. That sliding is very important when we go to assessing mobility of the spine. If somebody has a stiff spine, why is it that way? When you flex, the top vertebrae and the bottom vertebrae, actually the top one just glides forward or superior on the lower one. When you extend, the top one glides backward on the lower one. That's pretty much the motion in flexion extension. So the flexion one is a separation of the facet joint. Extension, however, is a compression of the facet joint. The two surfaces get closer approximated. So if you have an arthritic joint, if you have degenerative changes at your facet joints, they're going to be more painful in extension. So it's an important thing to really be able to identify. The vertebral body, when you flex and extend, also responds because of the shear forces, because they're attached to the vertebra above and below. When you flex, you get tightness in the posterior aspect of the disc, but the front aspect gets a little on slack, so you get a little bit of a bulge. The nucleus pulposus itself, though, in flexion moves backward a little bit because of that compression up front, and in extension, the nucleus pulposus kind of relatively moves forward. Not a lot. That's a lot of firm tissue in there, so it's a small change, but there is some shifting in the nucleus pulposus with flexion extension. With side flexion, the top vertebrae, right? So you've got two facets. So flexion looks like this, right? The top one moving on the bottom one. Extension looks like this. So when you side flex, it looks like this. All right? So you have an extension or a posterior glide on the side you're flexing toward, and you have a flexion or an anterior superior glide on the side you're flexing away from. That's where the coupling comes in. That's where that rotation, the tendency to rotation occurs.
Can you say that one more time?
Yep. So if I'm side flexing to my right, I'm going to extend basically on the ipsilateral facet, and I'm relatively going to flex on the contralateral facet. It's a similar motion of glide that occurs at the facet joints. Rotation is determined by the facet shape and the direction of the facet. There are bony abnormalities that influence this. So again, this isn't everybody every single time. There are some differences among people, obviously. But the rotation is primarily limited, especially as the facet is in the sagittal plane. So for those facets that are more oriented in the sagittal plane, you basically have the motion that's available for the superior vertebrae to move within the facets of the inferior vertebrae. Very limited. So with rotation to the left, you have a gapping on the ipsilateral facet joint and a approximation or compression on the contralateral facet joint. So if I rotate left, my superior vertebrae is going to slide to the right and jam up against that facet joint on the other side. So again, if I had an arthritic joint and I rotate left and they go, oh, yeah, that hurts on my right. That's that compression of those two facet surfaces approximating each other. In a degenerative joint, that's painful. So that can be another indication that there is potential degeneration of the facet joints. Protraction, retraction. Oh my goodness gracious. We see a lot of protraction, right? We see a lot of forward head position. Gravity is guilty of this, but also just our lifestyles are very contributory to this. Gravity actually has a line of pull that pulls the head forward. So our posterior structures need to help keep the head back and in line. We are able to protract actually about 80% more than we can retract. So we're in a relatively retracted position in neutral. I can only go back that far, right? But I can protract that much. So from a neutral or upright position, there's not much retraction available. When you protract, what actually occurs is an excessive extension at the upper cervical, but you get flexion at the lower cervical. So you're extending at the upper cervical, makes those little muscles, those upper cervical muscles, the craniocervical muscles, very short and tight. That's where you end up getting some of those tension headaches because those muscles are so short and tight trying to hold things together that they're not very effective. Retraction is the opposite, but we rarely have to deal with that scenario. This is again, the arthrokinematics that occur with global movements of the spine. So spinal flexion, we already kind of talked about this. Your facets glide up and forward with flexion. The posterior aspect of the disc gets tight. The anterior aspect has a relative bulge. So that's all the way along the spine. The posterior longitudinal ligament and facet capsules are really the primary restraint to additional flexion. So they get tight and really restrain things. So facet capsules and posterior longitudinal ligament. Supraspinous ligament is involved there too. With spinal extension, those facets are gliding down, approximating one another. This is limited primarily by the approximation of those spinous processes, right? One spinous process is going to jam into the other spinous process Just can't go any farther. If you go farther, you're going to fracture your spinous process. The lamina also help to control this motion. They are closely associated with the spinous processes, so they're going to get some bending force. The facet joints have some limitation, and the anterior longitudinal ligament. Abdominal muscles can help too, but that's a dynamic component. Side flexion we kind of talked about. Again, in the thoracic spine, it's limited due to ribs. So when you watch somebody bend to their side, you're going to typically see a little more flattened curve in the thoracic spine. Should see a little bit more of a curve, although there's only about 3% or so in the lumbar spine per segment of side flexion. But the thoracic spine is limited by how much rib mobility there is. Speaking of ribs, this is about all we're going to talk about ribs. I wish we had more time to talk about the thoracic motion, but we don't, and it's okay, because the rib movements are relatively important to understand as far as your breathing mechanics go. So you'll talk about these much more when you get to cardiopulmonary. So from our perspective, the rib movements 2 through 7, which are your upper ribs. Why don't I have 1 in there? Why isn't 1 included as a rib movement? Does it move? Right, it's kind of bound down by the clavicles, very tight capsular joints at the spine. It doesn't move a whole lot. But 2 through 7 actually move in what's called a pump handle. And you guys are way too young, unless you have a camp that has a pump, to remember what a pump handle looks like, right? But it pumps up and down like this. So your ribs in the front are moving in this plane. They're moving in the sagittal plane primarily. Part of that is because of the presence of the scapula and the upper extremities on the upper ribs, kind of holding things down from the posterior aspect. That's about the only way they can move. They're also tied to the manubrium, so that moves anteriorly, so that kind of helps that anterior motion as well. The lower ribs from 8 to 10 move in a bucket handle, so that's more in the frontal plane. So they're moving, they go out to the side like that. When you're working with somebody and they have a complaint of breathing difficulties or rib pain or mid-back pain and that sort of thing, it's very important to be able to feel the movement of their ribs with breathing. You can find things like a pneumothorax or something like that because of lack of movement of rib on one side or the other. So it's important to understand and be able to palpate and feel that rib movement. If you have somebody who's COPD or has emphysema and that sort of thing, they're going to pull in some accessory muscles. Those accessory muscles are typically the scalenes, right? Those they may include the sternocleidomastoid. They have really developed muscles here in the neck, and because of the attachment on the ribs, they can lift the ribs and help with breathing. So that you'll see that in someone with some breathing difficulty, COPD, emphysema, those kind of things. They'll have hypertrophy of their accessory muscles, and very little rib excursion down below. Very little. Oh, you guys ready for a break? Ben's squirming in his chair, so I think let's take 5. Because nobody else is telling me. All right, so we're going to look at the importance of the lumbosacral angle now. So this is the impact of their lordosis. How much lordosis does a person have? And there are consequences if they have too much and consequences if they don't have enough. It's basically the shear force of L5 sliding on S1. So if you have greater lumbosacral angle, and we're going to call it relative to the horizon. So about a 40-degree angle from the horizon. So it already is oriented down, right, to slide off the sacrum. The image on your left shows us less lordosis, and the one on the right is showing more lordosis. And if you look at the X and Y axes for those resultant forces, you can see with the one on the right, there's a much longer resultant force pulling down. The force sliding L5 off of S1 is much longer. So the tendency for L5 to slide on S1 is greater in a higher lumbar lordosis, a greater lumbar lordosis. Much more risk of spondylolisthesis or spondylolysis. You guys talked about that in anatomy? No, spondylolysis and spondylolisthesis, the sliding of one vertebrae on another. Yeah, okay. All right, I got a positive. So if you have a greater lumbar lordosis, you have a greater lumbar curve, you have increased shear, but it actually responds to compression a little bit better. So when you jump, when you run, that sort of thing, if you have adequate muscle control and muscle strength, you get a little bit better absorption of shock. If you have a decreased lumbar curve, a very flat lumbar lordosis, your angle is less, so the tendency of L5 to slide on S1 is less, but you also have much less shock absorption. So if you jump, if you run, you have a much more compression through the vertebral spine than you would otherwise. So like I said, there are consequences either way. One isn't better than the other. They're just consequences. The anterior shear force from a normal lumbosacral angle is about 64% of your body weight. If you increase that angle from 40 to 55 degrees, the force could increase to about 82% of body weight. So it really, really, really puts the onus on the muscle control to keep things in place. And on the ligament support. At the pelvis and SI joint or sacroiliac joint, again, this structure is designed to distribute force. So we're talking about the SI joints, the sacrum, and the innominate. The innominate is what we call one side of the pelvis, right? You've heard that term before. So when force comes down through the body weight comes down through the spine into the sacrum, that force is then directed around the ring, the pelvic ring, and it comes right into the pubic symphysis. Pubic symphysis is a cartilage ring. It's designed to take compression force. It's the perfect thing to have there, right? To take the pressure as those two innominates are pressed together from your body weight. There's also a distribution of force then through the femur down into the leg. The other consequence is when force comes up through your leg, it also is distributed around that pelvic ring, comes up through the sacrum into your spine. So force is transmitted both directions. The SI joints are fairly mobile in children. You can actually get a little play between the sacrum and the innominate. As we get older, I've seen some studies where at 30 years old, you basically, the SI joint in normal cases is fibrotic, which means there's not really any movement there anymore. You have some people who are hypermobile in the SI joint, so they may have more mobility later on. Women in pregnancy, what's really holding the SI joint together is ligament stability. and there's a roughened surface inside, but primarily it's ligament stability. In pregnancy, we have hormones that relax our ligaments. So as you get further into your pregnancy, the pressure from an additional human being inside of you, plus ligament laxity, they get a lot of SI pain. And that's one of the reasons they become a little more mobile in the SI joint with pregnancy. There are different schools of thought. When we get to manual therapy, we're going to be talking about manipulating the SI. We're going to be talking about mobilizing the SI joint. So just know that there are different schools of thought. I came from a school of thought that said, you know, the pelvic ring is dynamic. Bone is pliable. So is that deviation that you're seeing really from the innominate going, oh, or is it from the whole pelvic ring being pulled one direction by muscle? So is it a dynamic shifting of the pelvic ring rather than just one bone going on the other? So just know that there are different schools of thought. We don't always agree, but we're always amicable, right? So, so there are different techniques for treating things. Some work, some don't. Some work with one person and don't work with another, and that's part of the reason. So don't let it confuse you, but you will learn to kind of you'll kind of adopt one school of thought or the other as you work with folks. The sacrum is basically the keystone of the pelvic ring. What do I mean by keystone? You know what a keystone is in an archway? Right, it is like the main piece that holds the whole thing together. And that's the sacrum in the pelvic ring. So you'll get a lot of pressure through your sacrum with dynamic tasks. Movement of the SI joint. Again, these are terms that you're going to hear later, so I wanted to make sure that you were introduced to them now. And in the situation where there's a mobile SI joint, we're going to call them nutation and counter nutation. And what I'm talking about is the sacrum moving on the innominate. So this is your pelvis, your innominate. This is your sacrum. And when you nutate, your sacrum basically nods forward. So it's a relative posterior rotation of the innominate. Counter nutation is the other way. The sacrum actually gets back, or relative anterior rotation of the innominate on the SI, on the sacrum. So they're just two words that you're going to hear later, and I didn't want that to be a surprise. So we got this sacrum, which is holding, if you imagine it, all of your body weight coming down through the spine into the sacrum. So the sacrum is taking pretty much all of you and saying, I got this, right? But how is it doing that? How is it holding you inside the pelvic ring? As the body weight actually pushes down on the anterior aspect of the sacrum, it's a relative nutation, or it's a rotation forward of the sacrum between the two innominates. When that happens, your ligaments, your sacrospinous ligament, your sacrotuberous ligament, go very tight. It tightens those up. They're on the distal aspect of the sacrum, on the ischium and the pubis. No, on the ilium, the ischium. Anyway, they're down there on the bottom, and they're getting tight. So that's keeping that the sacrum from tilting forward. That nutated position is the closed packed, or the tight position of the sacrum. There are also a ton of interosseous ligaments. You guys did, dissected this out, right? You saw the sacrum. You can't even see the sacrum for the ligamentous support, right? It's in there somewhere, you know it, you can feel it, but the ligament support around the sacrum holding it within the pelvis is huge. So all of that gives stability to the SI joint. Another feature is the thoracolumbar fascia. So this is more dynamic support for the whole SI pelvic system. The thoracolumbar fascia is integrated into your lats. It's integrated into your glutes. It's integrated into your abdominals. When those muscles contract, it tightens that thoracolumbar fascia. It provides dynamic stability like a corset all the way around your abdomen. So it's a very dynamic support for the SI and the and your SI control, pelvic control. There's also the dynamic synergy of your abdominals and your erector spinae muscles. So the erector spinae, actually, when they contract and the lumbar multifidi contract, there is a nutation. So it pulls the posterior aspect of the sacrum, tilts it forward. The abdominals, biceps femoris, cause a posterior pelvic rotation. So that's tipping the pelvis posteriorly. Snugs up those ligaments even more and really helps to kind of firm that SI up in the SI joint, the sacrum in the SI joint. So there's a lot of dynamic stability going down there. And when we talk about getting core stability, having core stability, this is what we're talking about. All those structures that help provide support to your trunk that ultimately provides support to your pelvis and your SI. All right, we're going to be talking about that a little bit more. But let's do a review question. Did you get this one? What structures could potentially put pressure on the spinal cord if they are dysfunctionally lax? What can put pressure on the spinal cord if they are dysfunctionally lax? Read through those. Who says A? Who says B? Anybody for C? Anybody for D? B, right. Posterior longitudinal ligament and the ligament of flavum. Both of those ligaments are reside in the spinal canal. So if either one of those gets lax, it can actually have an impact on the spinal cord. Good job. All right, so internal torque. You knew it was going to come back, right? The strength that we derive from the abdominal muscles is going to be what we're calling our internal torque for the trunk. So the muscles that hold us up against gravity provide the internal torque opposing the force of gravity. The ability of a muscle to provide that support is based on its orientation, the direction of the fibers, and how close it is to the axis of movement. So it's no different from any of the other muscles we talked about when we were looking at torque production and moment arms, right? They're going to come back to haunt you here. So if we look at that first picture, longissimus thoracis is on the left along the spine. Rectus abdominis is in the front. Their lines of pull are fairly parallel with the spine. Which one has the longer moment arm for controlling spinal motion? You only have two to choose from. We still have another 40 minutes. I can be here all day. Which one has a longer moment arm for controlling? Where's the axis of motion going to occur when you flex or extend your spine? Where's the axis of motion? Rectus abdominis has the longest moment arm. That's not the axis of motion. That's the longest moment arm. Right? Your axis of motion is a vertebral body. The farther away you are from the vertebral body, the longer the moment arm for movement at the spine. Longissimus thoracis is pretty much right on top of the axis of motion, right? So is it able to flex or extend the spine very well? Maybe a little. Not like the rectus abdominis though, right? It doesn't have to work nearly as hard to cause flexion. The second picture, the external obliques, their line of pull is diagonal to the spine. It's not parallel. So there is a component of external oblique that flexes because it's anterior to the axis, but there's also a component of external oblique that does what? Rotates. How about if just one side activates? Side flexes. So because of that diagonal orientation, you're going to get rotation and flexion, and then, you know, side flexion if it's unilateral. What's the other? Oh, the iliothoracic long. The other erector spinae muscle there is parallel. That's just what that's showing. But they also show those moment arms, the difference in the moment arms. So the bottom picture, I know it's small and hard to see. The muscle on the anterior aspect is the external oblique again. And then you see the little multifidi back there by the spinous process. Which one has the longer moment arm? Which one's farthest from the axis of motion? External oblique has a longer moment arm, right? So when it comes to producing a rotational force, which is what this arrow is showing, the rotational force, the multifidi is going to have to work awfully hard if it's the only thing counteracting the external oblique for rotation force. We typically talk about the multifidi of all the transversospinalis because it has the best orientation. The others are very close to the axis. They're more for stability and compressive type force. So the multifidi is the one we're going to primarily talk about. So think about the orientation of a muscle. If you're strengthening muscles, if you are trying to establish which one is weak, you have to keep in mind how close it is to the axis of motion and what direction the fibers are. This is just kind of along the same thing. The external oblique with that diagonal orientation is going to rotate, and it's also going to side flex and flex. And then the rectus abdominis. So that's kind of the same deal. And this is another just a close-up of the external oblique and the multifidi. So, and that dotted line, that dashed line is the moment arm for external oblique. That solid arrow is the moment arm for multifidi. So definitely advantage to external oblique. When we look at the muscle activation in the axial skeleton, we have to think, is one side being activated or both? So is it unilateral or bilateral? Their motion and their activation are going to be different. If both are activating, then you're probably going to get flexion extension. If one side is activating, you're going to get rotation or side flexion with some element of flexion extension. So understanding their orientation, origin insertion, all of that is still very important. The other thing that muscles of the abdomen do is not just perform sit-ups right? They also stabilize the pelvis to allow movement to occur in other places. So as I'm walking down the hallway here, my legs are tugging and pulling on my pelvis. My rectus femoris, my iliopsoas, my glutes are all activating to make me move forward. If my spine, if my pelvis didn't stay stable and my abdominal muscles weren't holding me stable, I'd be kind of walking like this, right? That sort of thing. I've got to have a stable pelvis for my legs to function off of. I've got to have a stable pelvis if I want to throw a ball. So a lot of the action of the abdominal, of the trunk muscles is to provide a stable base for our extremities to function off of. Gravity is going to impact us, unless we're on the moon. So the type of muscle activation is going to depend on where gravity is and what the motion is. So if I flex my head, what muscle is making this movement look like this? And what's the activation? Slowly lowering my chin to my chest. Let's start with what muscles? Flexors or extensors? Let's just go with generalities. We have a vote for flexors.
The extensors probably eccentrically contracting.
I would probably say extensors eccentrically contracting, unless I do this, right? If I pull it quickly and forcefully, then sure. Yep, my anterior flexors are definitely doing the job. But if I am just letting my head slowly lower to my chest, the eccentric control is just allowing it to, is lengthening under tension. So think about how fast something is occurring and what, is it fighting gravity or controlling against gravity? Just a reminder of the orientation of the muscles in the craniocervical. You guys know this already. This is just a review from anatomy. And their orientation, whether they are deep or superficial, is going to impact their function, their lines of pull, their ability to create movement. So please have that in your brain. This is looking up at the cranium from below. That's the foramen magnum there and the back of the cranium. So the attachments that are there are the muscle attachments that are on the cranium. The grid, just to orient you, because I love these grids, you're going to see them for every single body joint that we look at, so I just might as well get you oriented. So if you look at the grid, the red line down the middle is the AP axis. The black line going across is the medial lateral axis. If something is anterior to the medial lateral axis, it's going to cause flexion. Those two lines meet right at the axis of motion of the head, right? So if something is posterior to the medial lateral axis, it's going to be doing extension. If something is falling right on the line of the medial lateral axis, it is likely not doing a whole lot for flexion extension, except for stability, potentially, because it's in the line of the axis of motion. Does that make sense? If it's on the right side of the AP axis, it's going to cause right flexion. If it's on the left side, it's going to cause left flexion. All right, so that's kind of the orientation of this. So it gives you an idea of the moment arm for the muscles, which ones are most effective for doing particular motions. So if I asked you which had a greater moment arm for extension, trapezius or longissimus capitis, you would say trapezius, right? It is farthest from the axis of motion. It has a longer moment arm. It is more effective as a cervical extensor. that make sense? If there are muscles that are on both sides, but only one side functions, then they're going to have just that unilateral axis of side flexion. So I find, I'm very visual, I find these graphs and pictures to be very helpful. If you don't, you can come up with some other ways to kind of remember this stuff, but this is just kind of a review of the location for everything. We're only going to talk about a couple of muscles. The ones that are that I find to be kind of important for our functional movement analysis. The others you need to recall from anatomy. So the sternocleidomastoid, I think it's fascinating because you get upper cervical extension, so extension of OA and AA, but flexion of the lower cervical spine. So it has a dual impact. It impacts the cervical spine differently depending because of the way the axis of motion crosses the cervical spine. So on that picture there, you can see the axis of motion is going to be anterior here. So you're getting extension of the upper cervical spine, and then it crosses this way, and now you've got flexion because of its line of pull. This is the muscle that really favors protraction. When it is tightest, that is the position that you are in. So it gets tight and short in a protracted or forward head position. If only one side is activated, if you're only activating your right sternocleidomastoid, you'll get side flexion to that side, so ipsilateral side flexion, but it actually is going to rotate contralaterally. So as it gets tight, it's going to rotate you left. So very, very interesting. I love that muscle. And then the scalenes, these are very important because of the brachial plexus running through there. They are accessory muscles for breathing. They provide stability to the cervical spine. So really important for us to understand. A lot of people have tight scalenes and complications and sequelae because of that. The brachial plexus runs between anterior and medial, which both insert on the first rib. And again, unilaterally, they do side flexion. They can rotate. If I am rotated left, the right will rotate me back to center. So ipsilateral rotation back to neutral. And bilateral, again, there's stability to the cervical spine. They pretty much run up and vertically parallel with the cervical spine, so that adds some stability, some compression. And then they can also, if the cervical spine is stabilized, they can lift the ribs. They work with some of the longissimus muscles posteriorly to stabilize anterior and posterior. The anterior scalenes also work with levator to stabilize the cervical spine. So they are acting from an anterior posterior orientation to the axis of motion. So if you have very tight anterior scalene, it's going to end up with a lengthened levator scapula. We want to have balance among these two muscles, anterior scalene and levator scapula. They're synergists for stability. And a lot of times we get tight anterior scalene, so then our levator scapula gets really fired up because it's working so hard to fight that tight anterior scalene that you get tightness, you get trigger points up in the upper and right at the base of your cervical spine. So levator can be a problem for some people with forward head posture. And then the longissimus, capitis, and coli, they're synergists with upper trap to stabilize the head as well. Those have an orientation very parallel to the spine. They don't do a lot for flexion. They're anterior muscles, but they really work to stabilize against the really, really powerful upper trap. And if the capitis and coli are functioning well, they will stabilize against the posterior pole of the upper trap to allow scapular elevation. You've got to fix one end of the muscle if you want to move the other one, right? So that dynamic fixation occurs with those anterior muscles. I just want to talk briefly about the suboccipital muscles. We talk about them a lot. They are frequently problems with people who have headaches, tension in their upper cervical. In that forward head posture, they get very short and very tight and very angry. They are very, very close to the axis of motion. So, and they're teeny little muscles, right? So if they contract, they just go boop, right? Boop. That's not a whole lot of motion, right? So they're that small. So really what they primarily function as is to give precise control, so fine control of the head at the upper cervical. But the main thing is they give feedback to the orientation of the head in space. Where is the head? What's the rate of movement? What's equilibrium going? What's, where is the head as far as tilt and orientation going? The coordination of your eye and your gaze stabilization with the horizon. It keeps your head oriented. So it gives feedback to the central nervous system on where your head is in space. So some proprioceptive input that comes from those suboccipital muscles. And again, that forward head posture, they're primarily 4 muscle groups that, that help to maintain that ideal posture. So in that forward head position, you've got levator scap and semispinalis capitis that are really under stress. Really, really, really working hard to fight gravity to keep your head up. And then the anterior lower muscles, they get tight and short. So if you're going to correct the forward head posture, you need to address the muscles that are tight and short by stretching. And the ones that are long and stretched out, you need to strengthen. So that's typically where we go with rehab, is to stretch the tight ones and strengthen the long stretched out ones. Just another note about the thoracolumbar fascia. It's the most superficial on the back. All those muscles blend with the thoracolumbar fascia. It's amazing. It provides coordination among those superficial muscles, the lats, the glute max, erector spinae, the abdominal muscles, and the multifidi. When the muscles tighten, so when there is good tone in the muscles, they actually provide kind of that corset support through the trunk. The transverse abdominis basically runs horizontally. When it snugs up, it provides support to the abdomen. The superficial and intermediate layers, especially in the thoracic spine, are more associated with upper extremity, putting the upper extremity where we need it. There is some assistance with trunk flexion, extension, and rotation, but primarily we're looking at what's going on with the scapula control and stability. So in this orientation here, you've got somebody in this position, right? So they've got to stabilize the scapula so that the upper arm, so that the humerus can be moved in a position where we want it. So the traps, middle and lower traps activate, serratus anterior activates. Those really help to stabilize the scapula against the rib cage. Posterior deltoid pulls on the scapula, right? So those other scapular stabilizers are giving it a stable surface to pull the humerus back. Long-headed triceps also inserts on the scapula. So again, got to stabilize the scapula so that those muscles can function distally. Proximal stabilization for distal mobility. And just to kind of lay out the posterior layers, these are the deep, deep layers of the trunk muscles. Your erector spinae are there, the longer ones over on the left, and then the transversospinalis muscles that live in the gutter between the transverse process. Correct myself up. Between the transverse process and the spinous process, right? Teeny weeny little muscles. They function to control movement between vertebrae. So individual segmental movement. All the other back muscles are global movers, right? They're moving the body and the spine goes along with it. Well, these are segmental. They are protective. There's, I've read some other studies where the multifidi and the transversospinalis muscles actually activate to fill the space, to provide compression within that gutter to stabilize that vertebral movement. Right? They kind of fill the space. It's in a fascial tube. It's in connective tissue holding these muscles together. And when they contract, it puts pressure against that fascial tube. It gives stability all along those spinal segments. Very important. And when people have had lumbar injuries, so you have somebody who comes to you with a lumbar pain, yeah, it's like every couple of years I get the same thing, you know, seems to be getting worse every now and then. They actually have lost the ability to recruit these transversospinalis muscles prior to doing something like lifting. So they have lost that fine segmental control at their lumbar layers, at the lumbar levels, that are necessary to support the spine during movement. So it's really important to recruit these muscles when they need to be recruited. And you learn how to do that. And then the erector spinae, that's, you know, they're big dogs, so I thought we'd mention them, but I'm not expecting you, this is not gross anatomy class, so I don't expect you to tell me which one is which, but just know that they all work to extend the spine. They all work to anteriorly tilt the pelvis. They provide side flexion if only one side activates, and they also de-rotate. So if I'm rotated left, my right erector spinae help me to de-rotate to the right. They provide gross control of the back. Like I said, they're just the big dogs. They do the majority of the work. Whether it's the right work or not, they are out there working. The deep layers of the erector spinae, they are similar to the levator scap, and that's why I thought this was kind of interesting. I almost took this out, but I think because they are similar, if you remember how the levator scap is really important for maintaining head alignment. It fights against all those other, fights against gravity, it fights against some of the other muscles. The deep layers of the erector spinae as well. They're fairly parallel, right, along with the spine. They don't have, the deepest layers don't have a really good moment arm for extension. They kind of lie in the plane of the axis of motion. So really what they do is compress, so provide stability. They also prevent some posterior shear because they are posterior to the axis of motion. So they become like dynamic stabilizers like the levator scap. And because of that, they can get mad, they can get tense and painful. The transversospinalis, we already kind of talked about this. Again, I just wanted you to see how teeny weeny they are. Some of them span one segment, some of them span a couple of segments. Multifidi are the one we're going to talk about the most, and those are, they've got a cervical example here, but multifidi tend to have the longer moment arms of the transverse spinalis, and they tend to span more than one segment. When we go to palpate the spine, they're a little easier to palpate in the gutter, so they're going to be the ones that you're going to be able to feel the most. And again, they help stabilize, they provide some rotation, but primarily they're proprioceptive. The abdominal muscles. They support and protect the abdominal viscera, right? You got to have something holding your guts in, and that's the abdominal's job. They also have an impact on the pressure, your intra-abdominal and your intrathoracic pressure. When we increase that pressure, sometimes that can cause pain. So it's important to understand the effect of that intra-abdominal pressure when we have somebody who's got some neural pain and some problems going on there. Obviously, they move the trunk. They support the lumbar spine and the SI joint. They are a strong preventer of anterior shear. When I talk to my patients about having strong abdominals, it's like, you imagine a table where you have two really strong legs, they don't wobble at all, and the other two legs on the other side wobble like crazy. Is that a stable table? Is that going to stay upright if you put any force on it at all? No, it's going to collapse. So those abdominal muscles act like stable legs on a table. They also, again, are going to stabilize the pelvis so we can move our hip and knee. So if our abdominals are functioning correctly, then we can stabilize our pelvis and move our extremities like we need to. Here's that famous grid of mine. Not mine, but I love them. So here's your axis of motion right through. This is L3. Right through the vertebral body. So here you can clearly see what has the longest moment arm for trunk flexion. Rectus abdominis, right? What has the longest moment arm for side flexion? Unilaterally, if they fire unilaterally. Anybody? External oblique. Yep. Longest moment arm. So it just kind of gives you an idea of the orientation. Quadratus lumborum does not have a very strong moment arm for extension. It, again, primarily does some compression and stabilization functions. Let's see, we have a couple minutes. Let's get through a couple more. Transverse abdominis, again, we talked about this, the horizontal orientation. When it contracts, it doesn't flex or extend. It basically just snugs everything up, like somebody yanking on the strings on a corset. Everybody's seen Gone with the Wind, when this is way before your time, where they have those lace-up corsets and they yank them really tight, right, and squeeze people in. Lord help us if that ever comes back. It has the most extensive attachment to the thoracolumbar fascia and the abdominal muscles. So it has a lot of impact on the thoracolumbar fascia. That's primarily its attachments. Oh, let's see. Okay, we can go another one. Okay, so the abdominal muscles function together synergistically to produce movement. So when you do a diagonal sit-up like this, you've got trunk flexion, you've got axial rotation, all happening at the same time. So your right external oblique and your left internal oblique produce that, in this case, left rotation, right? So they're working together, and then rectus abdominis and transverse abdominis are helping with that motion. So the abdominal muscles must be able to communicate and coordinate their movement for some nice smooth control. Okay. Okay, I think I'll give you a break. I'll stop here. We'll just finish these up next time. No biggie. Anybody have any questions from this for the exam? Any